a lot of other new surgeries in the market. And I'm going to talk to you about the ologen. Probably we have 2.5 years of experience with the ologen now. Initially, it was not very impressive for me because we know the ologen, the previous ologen, we know the results, not very impressed with that. So when we started using, we had used only for very selective cases, not in every given case. So I'll just share with you some of the results, what we have, at least for 2 years. Then you can understand whether you really want to use it or not. So the background, if you look at that, definitely we have the episteal fibrosis and subconjunctival tissue scarring is the major risk factors for the surgical failure in trabeculectomy. Especially the Asian eyes or the African eyes, we have more scar tissue formation than the European eyes or Western eyes. So this is a big concern. So we have to use mitomycin in a different concentrations depending upon the score we have. So but then either 5-FU or mitomycin has its own problems, more so with the mitomycin C, which is 100 times more potent than 5-FU as such. So if you want to avoid mitomycin, then we have other options. One of the options is the ologen. So ologen, what does it do? It really facilitates the repair of the connective and the epithelial ocular tissue and minimizes the random growth of fibroblast and modulates the wound healing in glaucoma surgery. So that is what is most important and which takes care of the other side effects of mitomycin. So this is our Indian trial. I won't say it is a big trial as such. It is not a very not a randomized controlled trial. It is a retrospective, non-randomized and non-comparative study, which the results we are going to show because we have just started the comparative trial and randomized controlled study. So the results we have to wait for some more time. But before that, I'll just show you this result. The aim of the study was to assess the safety and efficacy of the trabeculectomy with the ologen on the basis of IOP reduction, requirement of anti-glaucoma medications, and what complications we had with ologen. So there were 2 centers, my center and another one more center, one of our partner centers. So we have the patient can undergo a detailed ocular examination, and we have used, there are different types of ologen materials are available in the different sizes and heights. So we have used a cylindrical ologen in the size of 6x2, that is 6 mm is the diameter and 2 mm is the thickness. And we have 12x1 also, that is a little bit of square type, rectangular type. The 1 mm is the thickness and 12 mm is the overall size. So we have used 6x2 and we have calculated the preoperative IOP medications, complications, interventions, which we are going to show you now. The surgical technique, as Dr. Ganesh has shown you, the same surgical technique. We have taken a triangular spindle flap, but only with one single releasable suture, or whenever required, we have to put additional sutures. We have put that also. We have shown you here. We will show you that details as well. So the post-operative follow, the success rate was defined a little bit different in both the centers. The center one was the center Madurai. The IOP criteria where complete success was defined as less than 21, and in our center we defined it as less than 18, which is much more stringent criteria we have used. And you can see the qualified success is with the medication. If it is less than 21, we have defined as the qualified success. And in other center, it is less than 18 with the medications. As I've already told you, this is the number of eyes in both the centers, 58 and 35. And age group, mean age group, you can see it is quite a list. Mean age group, that is about 38 or 35, because we had included the congenital glaucomas and also the juvenile open-angle glaucoma. So I'll show you what are the patients as well. And the gender, you can see there's a slightly more in male preponderance was there. And this is the type of diagnosis we had. Primary open-angle glaucoma, angle closure glaucoma, where about approximately 40%. and secondary glaucomas, juvenile opening glaucoma and developmental glaucoma. So what I'm trying to say is the results you cannot generalize for your primary glaucomas. So we have to take consideration for all this. And also the number of patients undergone previous surgery, if you look at the center 1, had at least 90% of them had undergone some kind of a surgery earlier. So that is also will skew the results to some extent. We have used the releasable suture in all the cases, and some of the patients, you can see that about 30% of the patients in the center 1 had additional sutures. In our center, about 11% we have used additional sutures. I'll talk to you about how we can make the surgical success better in ologen cases as well. And this is the comparison of the results. I have shown you here up to 6 months of the results. The preoperative IOP was in center 1 was approximately 37.5, and the postoperative at the end of 6 months you can see about 14.5. So that is at the end of 6 months. And the center 2, the initial IOP was, the preoperative IOP was 28, and at the end of 6 months it was somewhere around 14. To define the complete success, 70% of the patients in center 1 had complete success in spite of having all the repeat trabeculectomies. Usually when you do the repeat trabeculectomy, the surgical success is much lesser. If you take 1 year, the end of 1 year, the repeat surgical success will be approximately about 50 to 60% at the end of 1 year, or even sometimes less than that when we use even mitomycin. So this has given about 70% success, and center 1, because we had more of primary surgeries, so 91.42 is the surgical success, and you can see the reduction in anti-glaucoma medications. So this is the new results. This is only from our center up to 24 months, but please see this with a little bit of care, because this is not a randomized control trial. And the number of cases at the end of 24 months is quite less. If you want to have a good p-values, then probably this number is not adequate. So all these 35 patients yet to complete the 24 months. So we have given you the breakup of number of eyes. From 35 it has gone down to 8. So be careful when you are looking at the results. So the preoperative being IOP is 28 at the end of 6 months. And you can see the postoperative IOP values 13.08. That is a good drop in intraocular pressure means. And also you can see how many people are on medication. There are 3 different failures. That is about 8 or 9% of them had a failure at the end of 6 months. At the end of 18 months, you can see only the number is only 40 patients, but almost we haven't had any failures. But the 35 numbers may be jumping into that level sometime. So at the end of 24 months, one of the patients we have used medications. In spite of that, they are still not under control. That is below 18 millimeters. But almost all the other patients are doing so well. So these are the main results which I wanted to show you. And this is the follow-up at 2 years. The number of eyes, though it is dropped, but IOP also equally very well under control. Only one of the patients we are still on medications, but all the other patients they are doing pretty good. And these are the complications. Please bear it in. You have to keep it in your mind that it is not that this is not having complications. This also has complications. Hypertony is one of the problems. In both the centers we had hypertony. The issue is when you are doing a releasable suture, then this is the problem. You might close it very loose, then there is possibility of leakage. So you can close it properly, and also if you want to put additional sutures, you can comfortably put additional sutures, but make it sure that you put a releasable suture so that you can release it a little earlier. Endophthalmitis in one of the centers, our first center, the issue was that tissue was exposed, and also the bite was taken through the ologen material most likely, or we have used the mitomycin also in the patient in addition to the ologen. So there is a possibility of endophthalmitis if you are not going to use it in a proper manner. So you have to understand that as well. So these are the interventions we have done post-operatively. One case had shallow chambers, so we have to reform the chamber, and quite a good number of them we happened to release the sutures in the center one. 23 patients had a releasable suture removal. In our center we had 7 patients. So these are the results which I wanted to show you, but then now with the 2 years or 2.5 years of experience, I can give you a little bit of tips. Probably you may be knowing a little better than us, but I can just share with you some practical tips which can probably augment your surgical success. You just do a proper trabeculectomy, but make sure that you put only single releasable suture. That is the best option you can have. But as I told you earlier, if you want to use additional sutures, you go for only additional releasable sutures. I will just show you the other videos as well. That is very, very important. The reason behind this, once you place the ologen tissue over there, if you want to cut the suture, your suture will not be visible for you to cut, because the ologen will cover the entire flap area. So you cannot see the flap sutures. So you have to use only the releasable suture if you want to do it. So that is one thing which you may have to learn if you have not learned your releasable suture earlier. Second thing is how much to tighten the releasable suture. Just form the chamber normal depth. Don't form it too deeper. Just form normal depth and then put just an approximation of the suture will do. If you are going to tighten it, then you are going to have a definite very high intraocular pressure. That is what we had in the initial few surgeries. We thought it is going to leak, and then we have tightened it, so it has caused more problems than less problems. Though the chamber is formed, but IOP is going to be really very high. So just make sure that you don't tighten it too much. This is one of the best ways you can possibly have it done. So where to place the ologen? Why we are so specific in that reason is, if you are going to keep the ologen a little bit just over the flap, then with the lid movements, the ologen moves a little bit forwards, especially when you take a fornix-based flap, and once the ologen gets exposed at the limbal area, then there is a very high chance that you can get infections, endophthalmitis especially. So don't put that just over the flap, just make it posterior. I will show you the video as well. It has to be more posterior. Size, initial ologens, the height was very too much of a height. It is about 4 mm. 4 mm ologen will not work for you. Either you use 1 mm or 2 mm height. That is the best we can use it. So you can keep either 6/2, or if you have 2 or 4 patients, then you can use 12/1, so that you can cut it into half and you can use for 2 patients. That is the way you can use it. And closure of the conjunctiva, again very critical. The reason is, if you are going to take through your bites, the suture bites through the ologen, this is when you use your bilateral sutures, it is a braided sutures. Once you use a braided sutures, there is always a transfer of infection from the external, because the sutures are exposed. External to the ologen tissue, then you are going to have a problem of endophthalmitis. So make sure that you are not taking your bite through the ologen tissue. That is very critical again. So I'll just show you the video. Hope it works. Okay, the first video seems to be. Okay, it works. Dr. Ganesh has already mentioned to you about the topical or subconjunctival anesthesia part of it. So this is the subconjunctival you can give if you are not very comfortable, especially in the advanced glaucomas. If you go into give retrobulbar or peribulbar anesthesia, then there is always a compromise for the optic nerve head. So you can just give subconjunctival anesthesia. And you punch, suture. These are all the normal steps of your trabeculectomy. So this is the time where you have to keep your ologen. This is again a trabeculectomy. Take your releasable sutures. Okay, this is how it comes in a pack. This is the ologen material. Just make sure when you are looking at the ologen, it has to be really spongy tissue. Sometimes it may appear to be a papery tissue, so don't use it. And also, so just keep it over the flap. So this is our initial videos. You can see that once the fluid is there, it imbibes the fluid and then it swells up. So it's always a very high chance for the migration of the ologen to the anteriorly, more anteriorly, or more towards the limbus. So it is better to be avoided if you are going to do that way. So that is our initial patients. We were not, we didn't have much of a clue. So once you do that, and then just keep it there and then switch it the routine way. See, learning ologen is not a big deal, but the only thing is how you can make it more, successful surgery. That is what is more important. So simply you can just close it. Okay, I'll just show you another video. The releasable suture. Take a releasable suture. In this video, I'm going to show you the additional flap suture, that is the interrupted sutures. This is a juvenile opening glaucoma. When you have a juvenile opening glaucoma or congenital glaucoma, you cannot just go with only single releasable sutures. It is not adequate. The reason is, by the time when you close the flap won't be in the same shape of the triangle. The central part of it would have shrunken and it will be in a different shape. So if you close with only one single releasable suture, there is going to be a leak on both the sides. So you have to use additional sutures if you are going to close the juvenile glaucomas or the congenital glaucomas. So you can use additional sutures, but only thing is you may not be able to see the interrupted sutures. So you may have to release the releasable sutures a little earlier than what you do with your routine mitomycin C surgeries. So this is another surgery, but here we have used 3 releasable sutures. Same ologen, we have used 3 releasable sutures, so you can remove the sutures at any time. In the sense, you can remove it at the earliest. 1 week or 2 weeks, or also you can release it. But just make sure juvenile glaucomas and congenital glaucomas, definitely you have to put additional sutures. Otherwise, you will face a problem of shallow chambers. So 3 additional sutures, 2 additional sutures, releasable sutures. But in some cases, you may face a problem of when you remove the sutures, it may get cut. The suture you may not be able to remove it fully also. So 3 sutures. Just adequately tighten it, don't tighten it too much. And then look at the way how it has fallen. So that's why I was telling you, if you keep it there, make it more posterior. Yeah, it has to be really posterior. Because of the lid movements, it comes forwards a little bit. So you have to be a little bit careful on how to keep the mitomycin, ologen. So what to look for intraoperatively, make sure that your pack is well sealed, it is not exposed. We had 1 or 2 packs which was little open, so you have to be a little bit careful. When